Good afternoon. My name is Dorothy Burridge, and I'm the Regional Education Coordinator with the Central East Stroke Network. And on behalf of the Central East Stroke Network, I'd like to welcome you to our webinar today, Stroke Rehab in the Younger Adult, Getting Back to Life After Acute Care. Just as a reminder, throughout the webinar, I would really encourage you to submit your questions by typing them into the chat or questions section of your control panel. I'm really pleased to introduce our presenters today. Dr. Audrey Yap is an assistant professor at the University of Toronto. She is the education lead of the PM&R division at Bridgepoint Active Health, Sinai Health, and she is one of the education coordinators for the Canadian Association of Physical Medicine and Rehabilitation. She has a special interest in healthcare education regarding accessibility for individuals living with a disability. Clinically, she has extensive experience in treating patients with complex musculoskeletal, spinal cord injury, and stroke rehabilitation needs. And this has included long-term follow-up of young adults living with a disability. Meghan Borthwick is a registered social worker with the Ontario College of Social Work and Social Service Workers. She obtained her master's in social work at the University of Southern California, and she is a social worker for the Stroke and Neurological Rehab Inpatient Service at Bridgepoint Active Health, Sinai Health. She has worked with the acquired brain injury and renal dialysis populations, and she's also experienced in community mental health and worked closely with high-risk adolescents going through life transitions. Danielle Gardner is a registered social worker with the Ontario College of Social Work and Social Service Workers. She obtained her master's in social work at the University of Toronto, and she is the outpatient social worker in neurological rehab, working with individuals with the lived experience of a stroke. Her previous experience includes servicing the inpatient stroke and neurological care, medical rehab, and renal dialysis populations. And she's also experienced in working with children and youth in a mental health capacity. So looking forward to your presentation, ladies. So please go ahead and thank you.
All right, thank you so much, Dorothy. And first of all, thank you to everybody joining our webinar. I know that we're in the midst of a pandemic and everybody has extra workload, so we really appreciate you joining us today. The first thing I want to mention is we're saying that the younger adult is less than 60. Please do not be offended. We think that 60 is still a young age. In the rehab world, there's your chronological age and then there's your physiological age. But when you look at the stroke population and you look at the stroke literature, less than 60 is quite young for a stroke. So that's why we've defined it as less than 60. So not to offend anybody who is 60 and above. And lastly, we are not experts on this topic. We are just like you. We're working with individuals that have had a stroke. And we would love to hear from you. Basically, what we've done today is we've just reviewed the literature, summarized it for you, and we're going to give you just tips and things that we find helpful in our practice. But we'd love to hear from you. So we have no disclosures. And just to sort of overview the purpose of this talk, we want to review what makes rehab for the younger adult stroke survivor different than the typical stroke survivor who's over 60. And we want to review the common challenges. And we also want to just review tips on how to address social determinants of health during stroke rehab and recovery. And we're using the term stroke survivor during this talk just because the literature uses this term. But of course, we just wanted to say that some people don't identify themselves as a stroke survivor. So again, please don't be offended by this term. We want to use whatever term that the person who has a lived experience after a stroke uses. But just for the purposes and convenience of this talk, we're going to use the term stroke survivor. Okay, so what are our objectives? By the end of this talk, we have 3 objectives for you. The first one is just to state the most common type of stroke related to COVID-19. We're not going to delve deep into this because we know that the Ontario Stroke Network has a talk coming up on COVID-19 and strokes, but we are seeing strokes in younger people because of COVID-19, so we thought it was important to include this. The second is, by the end of this talk, we hope that you'll at least remember 5 issues that are common and a priority for the younger stroke survivor. And those are both medical and psychosocial. And then thirdly, we hope that you'll be able to describe to your younger adult stroke survivor what their rehab journey might look like. So what we're going to do is we're going to tell you what the evidence shows, and then you can basically tell your patients what's the typical challenges that they might see and what are some of the outcomes based on the evidence. So what are we going to focus on? We're going to go through COVID-19 and stroke, then we're going to go through the medical and psychosocial issues. Obviously, there's lots of medical and psychosocial issues, but we wanted to focus on the ones that we thought we see as a team fairly often. So urinary incontinence, sexual health, depression, lifestyle factors, interpersonal and intimate relationships, and transitions in care. And when we say that we see this most often, we see this most often in pertaining to the younger stroke population. Okay. So an update on stroke from COVID-19. I am not an expert on this, but I did review some of the literature that's available. There was a systematic review and meta-analyses. Basically, they looked at all the literature from December 1st, 2019 to May 14th, 2020 to see any papers that mention neurological conditions related to COVID-19. So there were 42 articles, and it consisted of 82 neurological cases. The mean age was 62.3. 49% had cerebral vascular injuries. 28% had neuromuscular disorders, including Guillain-Barré. There was polyneuritis. There was also rhabdomyolysis, and interestingly, a small number of optic nerve palsies. 23% had encephalitis and encephalopathy. And when we look at the 49% that had the cerebral vascular injury, when you break it down, 87.5% had ischemic strokes, and that's in the main large vessels like the MCA, ACA, PCA. 5% were cerebral vein thromboses, 5% were intracerebral hemorrhages, and 2.5% were subarachnoid hemorrhages and intracerebral hemorrhages. So the theme here really is you see a lot of clotting and you see a little bit of bleeding in terms of cerebrovascular injuries or strokes. Okay, now when you look at stroke and COVID-19 in the younger adult, there was an interesting phenomena that was happening. It was so interesting that a case report came out May 2020, and it was rapidly published just because it was such a stark finding. In Mount Sinai Health System in New York City, they saw in a 2-week period from March 23rd to April 7th, there were 5 people that presented from the age of 33 to 49 that had large vessel ischemic strokes. What was so interesting was that they were less than 50 years old, and this was 7 times higher than their usual. What was also really interesting was 2 of them were either asymptomatic with any COVID symptoms or had a very mild respiratory symptoms. And also 2 of them had absolutely no cardiovascular risk factors. So this case report and other case reports from other hospitals have come to some conclusions that COVID-19 related strokes in younger adults can occur, but they can occur without typical vascular risk factors, and in people with no or only mild respiratory symptoms. So what was really interesting was one of the cases actually was only tested for COVID-19 because they had had a possible exposure. So they didn't even know that they were COVID-19 positive, but then they ended up having a stroke related to COVID-19. So essentially, the bottom line conclusions are healthy young patients who present with a stroke should be tested for COVID-19. And if you have mild COVID-19 respiratory symptoms and now you're getting new neurological symptoms, consider a stroke workup. Okay, so what's the cause of COVID-related stroke? An increased hypercoagulable state, that's what we're seeing. So we're seeing increased levels of D-dimer and fibrinogen, as well as vascular endothelial dysfunction. So we're seeing this inflammatory reaction. They're thinking that the virus is actually causing some type of inflammatory reaction within the endothelial cells. Unfortunately, the mechanism is unknown. So we don't know why you have this increased clotting due to the hypercoagulable state and the infection. We don't know the actual mechanism yet. But what's interesting, just looking at Stats Canada and the causes of death, I think everybody kind of knows that the top 3 are cancer, heart disease, and stroke. But now that we're living in this pandemic environment, COVID deaths are number 3, or have been number 3 in certain months in 2020. So COVID aside, how common is stroke in the younger adult in general? So when you look at all strokes, about 19% of strokes or TIAs are between the ages of 20 to 59. But what's really interesting is 4% of all strokes actually occur in people 18 to 45. And that's actually not an age that we think about with stroke, but we should still think about that because it does occur. And in terms of epidemiological changes, what we're seeing is the diagnosis of ischemic stroke in younger adults is on the rise. So why is that? We're not quite sure, but we are noticing that we're probably having better identification because we have better imaging now. But the other trends that we're seeing are there's a rise in the younger population of having obesity, hypertension, diabetes, hyperlipidemia, and as well the use of recreational drugs. So when we look at the stroke risk factors in the younger adult, some of them are just the same as any age. So hypertension, hyperlipidemia, diabetes, smoking, obesity, and now of course COVID-19. But things that are more prevalent in this younger population are things like contraception containing estrogen is a risk factor, pregnancy, migraine with aura, genetic conditions, and heavy episodic alcohol consumption. When I say heavy episodic alcohol consumption, I mean like weekend binge drinking is actually more common in younger adults. Of course, recreational drugs, and as well carotid dissection. Usually that's related to trauma, like from sports. Now again, interestingly, cryptogenic means we really don't know the cause. So up to 30% of strokes that occur in younger adults, we really don't know the cause. Okay, so what's the good news? And I think we see this all the time in our practice. Younger stroke survivors tend to have better neurological recovery. They have less functional disability in general, and they have greater long-term survival. Okay, but on to the bad news, and I always want to hand that over to our social workers to give that.
So the bad news is that young stroke survivors are more likely to exhibit signs and symptoms of depression and anxiety. Despite an overall good recovery, young stroke survivors report a lower quality of life and poorer social functioning. And lastly, young stroke survivors report a higher rate of relationship breakdown.
Okay, so next slide. So in order to start talking about some of the common issues and interventions that might arise in an inpatient and outpatient rehab stay, we're going to introduce you to our case today, Mr. A. So we've changed all identifying details, and we do recommend that you're mindful of this case throughout the presentation. So Mr. A is 45 years old, and he identifies as male. He was diagnosed with a right MCA in the frontal and parietal region, thought to be secondary to uncontrolled hypertension. His past medical history is significant for hypertension due to poor medication management, as well as hyperlipidemia. He has a normal BMI, no diabetes, and no coronary artery disease. He's been prescribed medications for antihypertension and lipid lowering. Functionally, he's exhibiting some left-sided weakness. His CMSA scores are 3 for his leg and foot and 5 for the arm and leg. In terms of his cognitive performance, he's scored a 21 out of 30 on the MOCA, showing primary impairments with visuospatial and executive function. He's also been observed on the unit exhibiting some poor insight into his functional abilities. Some behavioral changes have been noted, including increased impulsivity and easy to distract. In terms of his psychosocial history, prior to hospitalization, he was working full-time as a delivery person for Uber, and he was earning minimum wage. He had no access to any private insurance benefits. He is in a long-term common law partnership and lives in a 2-story walk-up rental apartment. Outside of his partner, he has a limited social network. He reported some history of cocaine use in his 20s, and he was using cannabis about twice weekly up until his stroke. Okay, so we're now moving on and imagining he's been in our rehab program for about 2 weeks and our assessments are done, and he's identified his goals. And, you know, we do in our work want to center our rehab interventions around the goals and priorities that our patient is presenting, and also taking some input from his partner and the team. So what he wants most is for his urinary incontinence to improve. There's been no presence of bowel incontinence. He also wants help for his anxiety and depression, which is new to him after his stroke. He notices his forgetfulness and the impact this has on his behavior, and he hopes to improve short-term memory. His partner and the team also notice that he's impulsive, and this sometimes displays overconfidence in his cognitive and physical abilities, sometimes leading to unsafe behavior. They note he may need support adjusting to these changes. His partner is expressing concern about their relationship and asking help to address this. And has some questions about his sexual health, and he's named this as important for his quality of life. Overall, he hopes to return home and also wants to get back to work after rehab. Okay, next slide.
All right. So in terms of the medical priorities for someone who's a younger adult stroke survivor, often it's no different than the average stroke survivor over 60 in terms of what their priorities are, but the order might be different. So for Mr. A, his physical rehab is number 1, but bladder and bowel, anxiety, and sexual health are at the top for him.
And then similar to the medical priorities, most stroke survivors will experience similar psychosocial concerns. However, the priorities might differ. So for Mr. A, the priorities to be discussed will be transition, mental health, depression and anxiety, partner relationship, and lifestyle factors.
Okay, so now we have a poll, and basically want to ask you, I troubleshoot around issues of urinary incontinence with patients, either often, sometimes, or never. And the reason why we wanted to ask this question was because, and Dorothy's setting that up. And the reason why we want to ask this question is because we as a team really feel that urinary incontinence, particularly for the younger patients, is a big issue. And we don't necessarily have all the answers, but we definitely wanted to bring that up and kind of tell you what the evidence tells us in terms of treatments and what we can do. Okay, so Dorothy, I can't see if people have answered, but you can tell us what the poll results are. Okay, are you there, Dorothy?
I am. So 22% say often, 51% say sometimes, and 28% say never.
Okay, across the board. Okay. All right. Okay, So let's talk about urinary incontinence post-stroke in just the general population post-stroke. So the incidence is up to 80%, and it usually resolves spontaneously without any intervention or treatment within the first 8 weeks after stroke. So that's really encouraging, and we can often tell our patients that. But most frequently, urinary incontinence is seen with more severe strokes, and if you had premorbid incontinence, for example, stress incontinence, with laughing or with sneezing or coughing, they have incontinence. But for the young stroke population, they've usually never had incontinence. So when you have new incontinence, they can find that, you know, they themselves feel it's socially embarrassing, or in terms of body image, this is something that is really bothersome to them. 14 to 19% persist at 6 months post-stroke, and that's when we look at all strokes. And the reason why I want to bring this up is that persistent urinary incontinence is associated with a poor long-term prognosis for functional recovery. But again, I'm going to give you the stats for younger strokes. Okay, so the younger stroke patient, less than 65, is actually more likely to regain spontaneous voiding ability. So 75.5% versus 50% in those over 65. So what are the causes of urinary incontinence after a stroke? There's many. Failure to store, so you might have a hyperreflexic bladder, and you're having incontinence due to the bladder spasms, or maybe failure to empty. You have kind of a flaccid bladder and you're retaining urine. Also, it could be a functional thing. So maybe you have poor mobility. You know when you need to go, but you just can't get to the washroom in time. Unfortunately, during rehab, that is a major issue. We have 1 nurse to 6 patients, so that is a common complaint that they're not able to get to the bathroom on time. Unfortunately, just due to the way our system is, this is an ongoing issue. In terms of medications, we know that diuretics can also contribute to urinary incontinence. On the rehab setting, we like to give our diuretics in the morning so that when nursing care is available, hopefully they'll have more of their urination during the day and not at nighttime. So what causes urinary incontinence after stroke? We actually don't know exactly what specific lesion in the brain causes what type of urinary incontinence issue. You can have a failure to store issue or a failure to empty issue with any, essentially any lesion in the brain. So unfortunately, we don't have good research on that. Okay, so how do we manage it? First, you want to determine the cause. Do they have a urinary tract infection? Are they on a diuretic? Are they drinking too much fluid? And if you're not quite sure, you want to log the fluid intake, the premonition. Do they have the urge or the sensation to go? How often are they going? And the amount. And from there, you can figure out a timed voiding schedule and also some timed fluid intake. General recommendations are limit coffee, alcohol, and possibly spicy foods, and wear clothes that are easier to manage. So for a young stroke population, jeans with a zipper and a button are probably not the best. Jogging pants that you can pull on and off are probably easier. There's also, we know that pelvic floor exercises or your Kegel exercises can be helpful. Medications, if needed, can be helpful. As a stroke rehab doctor, though, you want to weigh the risks and the benefits. A lot of the medications that work on the bladder can have some cardiac side effects, and they also can cause cognitive issues. So we use this very sparingly in the rehab setting. And of course, there's the accommodating practices, incontinence pads and briefs. If you really don't have a good solution, we're rehab. We do accommodating strategies. And then finally, if after, the 8 weeks or the few months, this person's bladder still isn't functioning, then we have to make a urology referral. I also wanted to mention that there are other things that you can do. There's acupuncture, electroacupuncture, TENS, which is transcutaneous electrical nerve stimulation. There's something called transcutaneous posterior tibial nerve stimulation. And but the Cochrane Review in 2019 said there's limited evidence. What is TPTNS? Essentially, you're stimulating the tibial nerve and causing neuromodulation on the sacral nerves to help with bladder function. And the reason why there was research on this is because we know that certain acupuncture points are over the tibial nerve, and that's how this all got started. But unfortunately, the studies have been very limited, and this is not gold standard practice. So bottom line, there are no easy solutions, and it really takes a team. So often I'm talking to the physiotherapist or occupational therapist. I'm saying, you know, when's the therapy? Trying to figure out when we should have the time toileting, and even if we try medications, just trying to make sure that, okay, do they have any cognitive side effects? How are they doing on them? So it really is a team effort. And as well, we just, as a team, just want to normalize it. Like, it's very common. You don't need to be embarrassed about it. We get it. And if accidents happen, we'll just help you clean up or get you to the bathroom on time.
So as we know, individuals who experience a stroke should be considered at risk for post-stroke depression throughout their recovery. Young stroke survivors are at an increased risk, approximately 50%, for a variety of reasons which we will discuss. In a recent study, researchers screened 250 patients ranging in age 60 years or younger from a Toronto stroke prevention clinic who experienced a TIA or mild to moderate stroke. About 40% of the young stroke survivors reported symptoms of depression, and approximately 42% experienced symptoms of anxiety. Interestingly, 30% identified with experiencing symptoms of both depression and anxiety. This is significantly higher rates than those reported in the older adult stroke population. The study highlights the importance of screening for both depression and anxiety after strokes, as research shows that anxiety is twice as common in young survivors, especially if they exhibit symptoms of depression. However, few studies have explored the anxiety among survivors who did not demonstrate symptoms of depression. It is evident that anxiety is an understudied symptom in individuals who experience a stroke, especially among the young stroke survivors. So research shows that despite a good overall, next slide, despite a good overall recovery, that young stroke survivors continue to report poor quality of life and social functioning post-stroke. While the specific contributors are unknown, I think it's important to recognize two aspects. One is the importance of celebrating small wins in rehab. Have you ever worked with patients who continue to express disappointment, the level of progress they've made this far, and the rehab team is pleased with their recovery? For instance, a patient continues to express frustrations with current transfer status. I think it's important to say, I hear you're frustrated with your current transfer status, but if you can remember, a few weeks ago, we were working on just enhancing your seating tolerance. Look how much progress you've made. I also think it's important to note that while this young stroke survivor is working on their physical recovery, they're also processing with their own emotions due to their current situation, which can be overwhelming. Young stroke survivors are trying to deal with the angst of the unknown. Are they going to return to normal? Are they going to get back to some level of independence? Are they going to be able to provide for their family and loved ones? And they're grieving an ambiguous loss. These are heavy emotions to process during a time that is so focused on physical recovery. And that's why I think at times young stroke survivors may not be able to recognize their physical gains because they're clouded by their emotional distress. So what can we do? And that's next slide.
Okay, so I'll tell you a bit more about what we can do as social workers when working with these patients that might be experiencing or at risk of experiencing post-stroke depression. So we do recommend use of a validated screening tool to screen for depression. We have named a couple of these scales on the slide: the Patient Health Questionnaire, the Hamilton Depression Rating Scale, and the Center for Epidemiological Studies Depression Scale. So these are best performing scales for identifying major depression disorder. Due to the brevity of this presentation, we have not listed all tools that are valid for use with this population. As such, we did want to highlight that the Canadian Stroke Best Practices, which are available on the Heart and Stroke Foundation's website, provides a useful table that clinicians can turn to review the psychometric properties of several screening tools that are valid for use with this population. Similarly, the Stroke Rehab Clinician's Handbook on the Evidence-Based Review of Stroke Rehab website also provides info on screening tools. So at Bridgepoint, Megan and I most commonly use the CASD. We thought it might be interesting to share some of our own reflections on using this tool in clinical practice with our younger stroke patients and survivors. So the scale contains 20 items and it uses a 4-point rating scale. In our experience, we have not found this to be very aphasia friendly. We find that sometimes it doesn't work well for folks with poor attention, and the language on the tool does not always seem accessible to those who might be experiencing difficulty understanding what they are hearing and/or reading. So with this in mind, we think we may want to review the table mentioned previously and always be open to introducing different tools that fit best into clinical practice based on the person's clinical presentation. As social workers, after we do these screens, we make sure to notify the physician and allied health team of any positive scores just to enable further assessment, diagnosis, and treatment options. We do have the luxury at Bridgepoint of consulting our great psychiatry team, who can then often provide further psychopharmacological management of post-stroke depression and anxiety. We think another important part of our social work role is to provide psychoeducation on depression and anxiety post-stroke. So this includes things like reviewing the signs of anxiety and depression, and also reviewing other mood states after stroke, and giving some tools on tips on how they, family, and caregivers can monitor mood. In doing this education, it's often a great opportunity to really name and normalize the experience of a wide range of emotions during the adjustment to illness process. As appropriate, we may also find time to acknowledge stigma that some folks might be experiencing talking about mental health, as we really want to allow people space and open doors to these conversations, which can then hopefully lead to more support and help. We also provide some education around mental health self-management resources that they might want to turn to. That leads me into the third part, or the third thing that we often do, which is facilitating access to community and mental health resources and supports. We do find the mental health system can be a bit complicated, so we do want to be hands-on in providing this type of care. So for example, we have some folks that might be interested in accessing further psychological intervention outside of our rehab program. So if that's the case, we can always provide information about what psychotherapy treatments are reasonable to suggest for post-stroke depression. And according to the literature that we looked at, this can include CBT and interpersonal therapy. Of course, the Heart and Stroke Best Practices also outline other emerging types of therapies and approaches to treating post-stroke depression. So these are things like music therapy and mindfulness. So we might also help our patients connect to those. We have named a couple programs on the slide just for your information, as they are currently being funded by the Ontario government, so they are accessible to folks living across Ontario. So that's digital cognitive behavioral programs through Mind Beacon and Ability CBT. So hopefully you can check those out online. Okay, next slide.
So as we know, lifestyle factors such as consuming alcohol, smoking, and/or use of illicit drugs are known as high-risk factors for strokes in young adults. Such activities may be common in the lifestyle choices of young adults. For instance, heavy episodic use of alcohol or other substances can be used as a form of socialization with their peers. However, refraining and/or limiting the use of such substances play a crucial role in a young stroke survivor's recovery. As a social worker, we work closely with patients using therapeutic techniques such as motivational interviewing and solution-focused therapy to address substance use post-stroke. It's important to maintain a therapeutic alliance and rapport with patients during these conversations, as they can be delicate. The goal is to make the young stroke survivor feel validated and able to share their thoughts and feelings in a safe and non-judgmental space. The role of the social worker is to assess whether the patient is willing and able to refrain from using, especially when adjusting and coping with their new norm post-rehab. It's also important to mention that sometimes these conversations include a harm reduction approach, and it's essential to begin with where the patient is at in their stages of change and proceed accordingly. In general, social workers will approach these conversations in two ways. Through motivational interviewing, social workers can help patients resolve and work through their ambivalent feelings about changing their behaviors or perceptions of substance use. The goal of motivational interviewing is to assess where the patient is relative to the stages of change and work towards finding their internal motivation to refrain or reduce substance use post-rehab. Whereas solution-focused therapy focuses more on discussing and collaborating on solutions to the problem rather than the problem itself. As a healthcare professional, you would discuss potential triggers, and that would be people, places, things, and HALT, never getting too hungry, angry, lonely, or tired, and solutions on how to avoid or cope with such triggers when they present themselves. For example, you're out with friends and families for a post-rehab celebratory dinner, not now because of COVID, but in an ideal world, and offered a glass of wine. It would be important to figure out how you would navigate or cope with that situation. Lastly, social workers will provide psychoeducation on the harmful effects of these lifestyle choices, best practice recommendations, and facilitate referrals to community resources and supports. Such resources include the RAM Clinic, Bellwoods, CODA, and CAMH. I also just want to recognize that I understand that not everyone has access to a social worker. So tips for all healthcare professionals who are engaging in these conversations about lifestyle would be start the conversation with where the patient's at. Be open and validate their lived experiences, rephrase and remain goal-oriented, and always feel free to refer to my guide to stroke recovery for additional support.
Okay, so social participation is another important part of people's stroke recovery process. When someone experiences a stroke, there may be an abrupt change or deterioration in the level of social engagement in their lives. So if we think of the typical young stroke survivor, this might include things like a complete interruption in their work life or recreational hobbies. The presence of social participation and social support are considered protective factors for mental wellness and are also known to contribute to improved outcomes in stroke recovery. So this is an important reason why we want to focus on this in stroke care. So how do we do this? Well, one way is peer support groups. So we have found that that's something that young stroke survivors want more of. So as social workers, we let them know where they can find those groups, and some options that do exist and that you can look to are through the Brain Injury Society of Toronto, March of Dimes, and the Ontario Brain Injury Association. We'll also give education on why they might want to join and how they might benefit from a peer support group. So this includes things like the opportunity to share stories and coping strategies, build new relationships, find normalization for their experiences, and also learn new ways to manage their chronic illness. We also recognize that peer support is not for everyone, and sometimes one-to-one support might fit better. So another way that we can enhance social participation is empowering informal support networks that already exist in people's lives. So you might just do this by having conversations and helping people work out how to ask for help and talk about their needs with those around them. And I think it's important to keep in mind that decreasing social isolation might also be a protective factor for onset of depression. Okay, now we can go on to partner relationships. So we find that partner relationships are another important part, or an important part of life that it is impacted by stroke. So first of all, what we found in looking at the literature is that there is a limited number of studies in this area. We looked at a systematic review of 39 quantitative and qualitative studies in which the study participants range in age from 21 to 90 years old. We want to note some of the limits to this research. It only included samples of married heterosexual couple relationships, so obviously this is not representative of the diversity of real life relationships. They also had small sample sizes, and there were no specific conclusions made around the influence of age and gender on marriage outcomes. Nonetheless, we did find some important and helpful information. So one study showed that separation and divorce rates are actually higher in working age stroke survivors with children. The systematic review also demonstrated lower relationship satisfaction in the spouse compared with the stroke survivor. And this was thought to be because of things like spouses were bearing the brunt of caregiving task load and perhaps relationship inequity. Excuse me. The systematic review also named 3 themes in marriage post-stroke, which we thought was helpful and something that we can give education around to the people that we're working with that are experiencing this. So the first theme was chaos in marriage. So this was what happened right after the stroke. So that also often comes with abrupt change in roles and responsibilities, which leads to shift in power dynamics in the relationships, and in turn can change things like communication and intimacy. The second theme was reworking to reestablish the marriage. So notably, it was thought to take greater than a year for a spouse to realize that the hoped for marriage may no longer be possible, and then engage in the process of acceptance, renegotiating, and recreating the relationship. And then the final theme they named was the evolution of the marriage. So this was finding new meaning and finding ways to reconnect and finding marital closeness once again. One study did find that 2/3 of couples were able to retain or regain the closeness in their relationship, and that closeness in the marriage after stroke was associated with better outcomes for stroke survivors. Next slide.
So themes to be cognizant of when working with young stroke survivors and their partners is a phenomenon called the survivor perspective versus the spouse perspective. So the survivor often feels that their loved one has become a caregiver, worried about their safety and ability rather than their spouse and support system during their recovery. Whereas the spouse may feel emotionally distanced from the partner, they spend limited quality time together outside of care as they lack a common interest. It's important to encourage young stroke survivors and their loved ones to be mindful of each other's perspective during this difficult time. While the survivor may feel that they are a burden to the spouse, and the spouse may feel that they are emotionally distanced from their loved one, they need to come together mutually to feel supported. It is all about perspective and having an open and honest conversation with your partner throughout the recovery process. And this is also seen in themes of a strong partnership. So the common themes of a strong partnership is a commitment to a partner or marriage. Just the next slide. But it's the classic vow for better or for worse. It's important to reestablish the new understanding of roles within the relationship, reconnect emotionally, and set healthy boundaries. For example, I had a previous patient who him and his wife had set these healthy boundaries about visitation. So for instance, she only visited the hospital 5 days a week, but they used humor and their strengths within their relationship they called it like Freedom Friday and Sunday Fun Days. But this was able to provide boundaries so the patient had a sense of control and autonomy, and it also offered the spouse a day of respite and self-care. But more importantly, when they were spending time together, it was quality time. The other theme of a strong partnership is using strengths within the relationship in a mindset of we are a team and we are in this together. And this often looks like starting a new activity together to spark a common interest. A previous patient started kayaking, and not only helped with his building his strength of his left upper extremity, but his wife paddleboarded. So this was an activity that they could do together.
Okay, so what can we do to support couples in their relationships while also supporting caregivers? So we found in the literature that interventions targeted to enhance couples' communication had the largest effects on health and relationships. So what does improving communication mean? It's things like expressing emotion, sharing concerns, and communicating about needs. Spousal stress is often attributed in our conversations in rehab to issues around the spouse coping with care rather than the couple's relationship. So we thought this was interesting, given that the systemic review on marriages post-stroke actually indicates that caregiver supports that target increasing caregiving skills are actually not likely to reduce the strain in marriage, in which the spouse is a competent caregiver, but most of their distress is actually coming from the stroke survivor's behavior or their dissatisfaction with the marriage itself. So this just makes us pose a reflective question to the group about what's more important. Is that respite and those types of caregiver supports, or is it linking a couple also to relationship counseling or psychological supports focused on helping them enhance their communication and finding that new meaning that we talked about earlier? So it also makes us wonder about future research. Is this an opportunity, or are folks listening maybe have some information about this? We'd be happy to hear about it. But we definitely wonder, can people benefit from more support around their relationship on top of the other types of caregiver supports that we often refer to, such as respite or caregiver support groups? So I'll move on to the next slide. So what are some tips that we came up with for your patient if this does come up and they present with strain in their relationship? So first of all, mutuality. So even if talking about how even if you have a serious physical limitation, you can still give emotional support to those who you care about or find other ways to support those around you. Reconnecting. So doing the activities they love to do together, and if that's not possible, finding new activities to engage in, similar to what Megan mentioned earlier. Autonomy. So we know a lot of the people we work with might be adjusting to a sense of a lost autonomy or control over the roles and responsibilities in their relationship. So we can support them about how to regain a sense of control in those relationships. Body image. We can talk about things like body positivity or self-care that helps them feel good about themselves. Power balance. So talking about how it's about finding a balance between giving and receiving assistance in a way that's agreeable to both partners. And finally, socialize together. So emphasize the importance of finding their tribe, whether that looks like a new group of folks or people that they were socializing with before the stroke, and helping them see that socialization has value and brings value to life. Okay, next
All right.
slide.
Okay, so we're going to skip the poll question because I know we only have 10 minutes left. Time goes by fast. So let's get right to talking about sex. Mr. A wanted to talk about sex, and he basically says, am I ready to have sex? Will it cause another stroke? So many issues come up. Body image, like Danielle was talking about, bladder and bowel you have to talk about, and just because you have a disability doesn't mean that you can't get pregnant or someone pregnant. We want to talk about STD prevention. We want to talk about increased or decreased sexual interest and arousal. For Mr. A, he was a little bit frontally lobe disinhibited, and so maybe he was more sexually aroused. He also had some executive function and impulsivity, and his partner was noticing that. So in terms of the medical questions, you definitely want to ask in terms of their cardiac health, can you climb 2 flights of stairs without cardiac symptoms? So for Mr. A, he didn't have cardiac symptoms, but a lot of our patients do. Are they short of breath? Do they turn blue? Are they able to do those 2 flights of stairs? It works out to be an average of like 3 to 5 METs. So sexual activity is about 3 to 5 METs, or metabolic equivalents, which is about 2 flights of stairs. Or can they do moderate exercise? So the bottom line is really, yes, you probably can have sex. You want to just go slow at the first, but most people after a stroke who have sex do not have another stroke. So just to reassure your patients, yes, they're probably safe if they can do some moderate exercise. But other things you want to think about, you want to talk about their bladder, their bowel, spasticity, pain, and is weakness getting in the way? So when you look at the studies, it is limited studies, and it's usually based on self-reports in terms of what their sexual health is going to look like. Most were done in males, and most studies focus on the married heterosexual couple. We have no studies on how culture and disability and sexual health all interplay. And we really have conflicting results regarding sexual dysfunction and the stroke location. So in terms of low libido, really, what are the different lesions? There's conflicting results. And as well, in terms of sexual dysfunction, that there really is no specific lesion in the brain that's associated with that. But what do we know after stroke? We do know that in general, most people have a lower sexual interest and arousal, although sometimes for the frontal lobe, you might be more sexually aroused. But in general, people have reduced sexual activity and reduced ability for erections, ejaculation, orgasm, and vaginal lubrication. So what are some tips? The first thing you want to do is you want to encourage them to just practice on their own. Self-stimulation, trying to figure out what feels good, what doesn't feel good. Your sensation might have changed. You might have some hemiparesis. You should try to experiment on your own, and it's okay to do that. The other thing is you don't have to jump right into having sex. You can reintroduce intimacy, holding hands, hugging, cuddling, or kissing. If you have aphasia, create your own language. So a parent in the morning, but if that's the time when you have the most energy, why not? Try to figure out what's best for you. Avoid large amounts of water 2 hours prior. Empty your bladder prior. Avoid alcohol because that can reduce the sexual responses. Make sure you use contraception and have STD prevention. Have lubrication on hand. Have pillows on hand, extra pillows, particularly for your hemiparetic side. And you may need medication, things like Viagra or Cialis, but of course there can be some cardiac side effects, so we have to weigh the risks and the benefits. And lastly, anticipate setbacks. So just with any activity, you might not master it on the first time, and just try and try and try. Okay. So these are great resources. So the stroke engine, I love the patient handout. So just as a baseline, you can print out the handout on sexuality from the stroke engine. And this is actually the Pleasure Able manual is free online. And if your patient is in a wheelchair, there are actually very detailed pictures on different sexual positions in a wheelchair. This is a really fun book, A Quick and Easy Guide to Sex and Disability. It reads like a comic book. It's very user-friendly, and your patients can buy it off Amazon for about $12. If you're a clinician and you're wanting to know more about sex and disability, The Ultimate Guide to Sex and Disability is a great book and reference. And then now moving back to like more lifestyle factors. Exercise, I'm a physiatrist. We always promote exercise. Exercise helps with everything. Basically, the Canadian guidelines are 150 minutes per week of cardiovascular exercise. It improves so many things. It improves your brain health, lowers blood pressure, improves cholesterol, controls your blood sugar, reduces sleep apnea, improves mobility, and improves your bone health. And here's a great little guideline for any clinician who wants to get somebody started with exercise after a stroke. And the first step is always, what are you interested in? And just like Megan was saying, it might be a new activity based on your partner or based on your new impairments. So just consult your allied healthcare team and of course get your rec therapist involved. The bottom line is if you can think about it, there's probably an adapted way to do it. So Parasport Ontario is a great resource. They have lots of adapted sports activities. And then lastly, we're talking about transitions in care and people want to know, will I be able to go home? So the good news is if you're less than 50, 95% of stroke survivors go home. Of course, there's always the 5% that don't go home. They have to go to a chronic care facility, even if they did go to rehab. And the literature suggests that the reasons for not going home are a severe stroke, lack of a supportive caregiver, or maybe the caregiver's health deteriorates, or maybe the caregiver is unable to cope with the continuous stress caused by the increased care requirements. And of course, just like Danielle and Megan mentioned, there could have been also relationship breakdown.
So when looking at
Megan.
transitioning a young, when looking to transition a young stroke survivor from rehab back to the community, it's important to address additional psychosocial stressors. We went into a little bit more detail, but just being mindful of time, that might look at resource need, finances and income support, housing, so either alternative housing or informal and formal supports that we can put into care in your environment. And lastly, a referral to outpatient rehab and community programs where patients can continue to receive interdisciplinary support while working towards their goals.
Okay, so going back to the case. So Mr. A, he did have some improvement in his hemiparetic side. His leg is now a 5 and his arm is now a 6. His urinary incontinence resolved with time, as it usually does after about 8 weeks and in younger stroke patients. And he maintained an intimacy and resumed sexual activity. And in the end, he didn't need medications. And that's what we usually see when you do have that physical recovery. Usually it does mimic the sexual health and sexual health responses return.
So he has also been recognizing his needs a lot in conversations, and he's been accepting some assistance with some instrumental activities from his partner. He's also been referred to a CBT psychotherapy program for further treatment of depression and anxiety, and he will continue to receive medication treatment overseen by his psychiatrist. He's joined a peer support group to help with adjustment to illness. Partner reports high stress and also joined a peer support group. The partner relationship remains strained, although the couple has identified that they're going to start doing some daily walks together to spend quality time.
And so just to end off, we've just been so impressed by our patients, and we wanted to just read a quote. The stroke was both the worst experience and one of the best experiences of my life. The stroke gave me the opportunity to reevaluate my life and my career and think about what I want and what makes me happy and fulfilled. And when Danielle, Megan, and I, read this quote, this is in the Stroke and the Young resource manual, it really resonated with us. I've just been flabbergasted as a physiatrist. Many, many patients of mine who have significant disabilities have said this to me. They've said things in other ways saying, my disability was a gift. And we just wanted to reflect that even though you might have a disability now, you may not be able to do the things that you used to be able to do, you can still live a full and quality life. And this is what our patients have taught us.
Okay, and I'll just go through this really quickly. What are some of the most important things we can all do as healthcare professionals? So we think to listen and foster a safe space. So just give time for reflection, for people to talk about the impacts of their illness on their life and all the changes that they are trying to adjust to. Also advocate, which can happen in so many ways, but always making sure our patient's voice is heard first and at the center of the table, and find ways to use the right language to get people the services and the supports they need. So maybe this means filling out forms in a timely manner and knowing what language will get them those supports.
Other really important things is educate your patients and families. Knowledge is power, and education should be provided to patients and their family throughout the continuum of care. Validate and normalize their experience. This is typical. Many people have shared this experience. This often occurs. Managing expectations in one's recovery and adjustment to illness. For example, if a patient's goal is to return to driving, I hear that that's a goal, but this might be a long-term goal that we can explore in an outpatient capacity. I think it's also important to be mindful of accessibility of information, language and communication needs, i.e. using aphasia-friendly tools if necessary, and cultural considerations. And lastly, motivation. Celebrate the small wins, keep it goal-orientated, recognize their strengths and resiliency throughout this journey. I think it's, we have to remember there's going to be good days and bad days, but it's all about riding the wave of recovery. We recognize that it takes a team, so thank you to all of our interdisciplinary rehab colleagues.
So thanks so much, everybody, for joining. These are our references. I'm sorry we didn't have time for questions, but thank you so much for joining us today.
So I'd also like to thank Dr. Yap, Megan, and Danielle for presenting today on such an important topic. I will let you know that this webinar has been recorded, and once it's uploaded to the Central East Stroke Network website, I will be letting everyone know the link. And again, for anyone who did post a question, we will certainly do our best to find the answer and circulate that information again. So thank you so much, Dr. Yap, Megan, and Danielle, and thank you to everyone who took the time out of such a busy time in your day to join us as well for this webinar. Thank you very much.
Thanks
for the opportunity. Bye.
Thank you. Bye-bye.